Hello students, myself Dr. Maddineni Srinivas, your Dermatology faculty in Cerebellum Academy. So in this video, we are going to see the previous year questions of INICET May 21. This is the first MCQ which says a 65-year-old guy arrives with tense itchy bulle over his limbs. The roof of the bulle collapsed after a few days. What is the most likely diagnosis shown in the clinical image below? So with this history, if you are aware of the most important chapter, which is immunobullous disorder, and if you are thinking in terms of immunobullous disorder as the answer, you are going in the right way. And by looking at this itchy bulle, if you have thought about the diagnosis of a subepidermal blistering disorder, which is bullous pemphigoid, you are absolutely correct. You are absolutely correct. And what are the points which are in favor of bullous pemphigoid diagnosis? So the age group, which is the elderly age group, which we are going to see associated with bullous pemphigoid, 60 to 80 years. And yes, tense bulle, that is also one more very important clue, and itchy bulle. Please remember, in bullous pemphigoid, the tense bulle can be present over normal skin, or they are going to be seen over the wheals. Okay, the roof of the bulle collapsed. So what is this? This is actually telling about one concept in bullous pemphigoid, which is settled bulla, which simply says that, please remember, in bullous pemphigoid, the lesions, the vesicular lesions, they are going to have a tendency to heal. There is no tendency to extend, but there is a tendency to heal. That is the reason why the tense bulle rupture, the fluid comes out, and the bulle are going to just settle down onto the skin, but they are not going to extend onto the normal skin. That is the point which is given in this collapsed bulla, Okay, coming to the rest of the other options. So this is a picture of a patient of pemphigus vulgaris, where you are able to see again the vesiculobullous lesions, and now you are able to see that these lesions, they are extending on to involve the normal skin, the surrounding skin. So this is very characteristic of pemphigus vulgaris, and this is the reason why previously, when the treatment was not properly known, the patients used to have a very high mortality rate ranging from 80 to 90%. But thanks to the steroids, with the advent of the steroids, now the pemphigus vulgaris mortality rate has reduced drastically. Oral steroids are very important. And can you tell me what is the underlying mechanism responsible for these extended lesions, which is clinically demonstrated in the form of Nikolsky sign? The underlying mechanism is called as acantholysis. Acantholysis. Seeing the next image, here you are able to see that there are excoriated papules which are present over the extensors. Extensors having the excoriated papules, think about the diagnosis of dermatitis herpetiformis. So remember, there is association with gluten sensitive enteropathy. So these individuals should avoid brow, barley, rye, oats and wheat. So in this image, you are able to see that there is this classical annular lesion which is surrounded by a rim of vesicles, which is giving a descriptive term which is called as crown of jewel appearance or cluster of jewel appearance. And this is a lesion which is classically seen in linear IgA disease, which is also called as chronic bullous disorder of the childhood. Very important to remember the lesion which is seen in LIG. This is the next MCQ. 20-year-old young female presented to the Derma OPD with the following forehead lesions. And you are able to see over the forehead, there are multiple black heads. There are multiple black heads. There are also multiple white heads, which are able to see here, white heads. So blackheads and whiteheads are the layman terms for open comedones and closed comedones. So these kind of lesions are seen in acne vulgaris. And now the examiner is asking which of the following methods won't help with the treatment of various stages of this condition. So option A, topical benzoyl peroxide can be used in the treatment of acne vulgaris. Yes. Topical tazarotene, it is a retinoid, and this just like adapalene and tretinoin can be used in the acne vulgaris. Topical antibiotics, I hope you all know that topical clindamycin, nadifloxacin are very much used in acne vulgaris. So what is the remaining one? The topical fluocinolone, which is a steroid. Please remember this very important point. Topical steroids are never used in acne vulgaris. Do remember this very important point. Topical steroids have no role in acne vulgaris. This is very important point for you to remember. This is the next question. In a 45-year-old male who is hailing from Bihar with a normo-anesthetic hypopigmented lesion and a history of prolonged fever in the childhood. So what is the probable clinical diagnosis considering the absence of thickened nerves? So please remember, whenever you get a question mentioning a patient hailing from Bihar, always think about two important differentials. One is leprosy and the other one is leishmaniasis. Another one is leishmaniasis. In the MCQ, it is very clearly mentioned that there is absence of the thickening of the nerves, but there is a presence of one positive history, which is a prolonged fever in the childhood. So with these two important clues, please remember it is PKDL which you need to think about, which is post Kala Azar dermal leishmaniasis, PKDL. And what is the importance of this prolonged fever? There is going to be an infection with Leishmania donovani, which if not treated properly, then it is going to land up into this condition called as PKDL. So when there was initial infection, which is Kala Azar, due to the Leishmania donovani, Kala Azar, patients are going to have the clinical manifestations of hepatosplenomegaly and also prolonged fever. Okay. So now the patient is landing up into PKDL, presenting with multiple normoanesthetic hypopigmented macules over the body. Not only this, there can also be nodular lesions present over the face. So if you look at these differences between the conditions, the hypopigmented macules and infiltrated nodules are common for both lepromatous leprosy and PKDL. So how can you differentiate in PKDL? Yes, as given in this question, prolonged fever history is going to be there. And of course, if you do a GIMSA stain, we can see LD bodies, which are Leishmania Donovan bodies. And they are not going to be seen in lepromatous leprosy. Whereas in lepromatous leprosy, thickening of the nerves, nerve abscess can be given, or there can be mention of a claw hand due to the sensory and motor involvement. These changes can be there. Tropic ulcers, lag of ophthalmos, exposure keratitis. All this can be mentioned in lepromatous leprosy. Okay. This is the next MCQ. What is the most probable diagnosis for a child who has asymptomatic lesions on the forearm and also shaft of the penis? And if you look at these lesions, you are able to see that there are tiny shiny papules. Tiny shiny papules which are present over the penis. And if you observe carefully, some of these lesions, they are having this linear pattern, which is telling us about the Koebner's isomorphic phenomenon being positive. So with these clues, if you have thought about the diagnosis as lichen nitidus, you are absolutely correct. Please remember, lichen nitidus has nothing to do with lichen planus. It is a separate entity where clinically there is going to be presence of small shiny tiny papular lesions, more so commonly over dorsum of the hand and also over the shaft of the penis. More likely children are the ones who are going to have these lichen nitidus lesions. Okay, so these are all the important clues which you must remember. So this is another picture where you are able to see this tiny shiny papules present over the elbows. And important histopathological term related to lichen nitidus is claw clutching ball appearance. So what is this? The claw is formed by the rete ridges. So this is the rete ridge which is forming this claw. And what is the ball? It is a lymphocytic infiltrate present here. So this is the ball. So this is the claw clutching ball appearance as described in lichen nitidus on histopathology. So there was one more option, which is scrophulosderma. So please remember, in the scrophulosderma, which is a cutaneous tuberculosis, there is going to be a presence of these kind of scars, sinuses, bridging scars can also be present. And what is the underlying reason for this? There is going to be a focus of infection with MTB bacilli, like for example, most commonly cervical lymph nodes, or it can be even the joints or the bones. So the MTB bacilli, they will proliferate and they will form sinuses onto the skin surface. They are going to produce these discharging sinuses, and later on they are going to form the ulcers and they will heal with the scarring. So this is the scrophulosderma, which is going to present like this. So this is the next question: which among the following is correct regarding healing of leprosy if left untreated? So leprosy is a very, very important topic. As you can see here, this is another MCQ related to leprosy which is asked. So let us look at the options. No spontaneous remission is seen. This is absolutely wrong statement. Why? Because there is going to be almost in any person who is having contact with Mycobacterium leprae. Just take for example, we dermatologists who come in contact with the leprosy patients very frequently. In a day-to-day basis, every day we are in contact with the Hansen's patients. So, but remember, there is going to be a very good spontaneous resolution or remission ranging of 80 to 90%. So with this number, you already know that the option B is also wrong. Why? Because it is mentioning that only half of the cases resolve spontaneously, but whereas it is actually 80 to 90%. So this is also a false statement. So the next statement says spontaneous remission is more common in children than adults. Please remember, in children, the immunity is not very much well developed. And remember, M. leprae presentation or remission is mainly dependent upon the immunity. So the immunity is good in adults. So the spontaneous remission is more better in adults when compared to the children. So this statement is also wrong. So we are left out with one option, which is going to be the correct answer. Indeterminate leprosy has more remission than tubercular leprosy. Simple funda, simple reason for this is because indeterminate leprosy has few bacilli when compared to the tubercular leprosy, in which more number of bacilli are there than indeterminate leprosy. So answer is going to be option D. This is the next question. I hope you all by this time can easily identify what is the diagnosis. So in a young man presenting with painful lesions, and what is the description you are able to see in this image? There are multiple grouped vesicles, beautiful grouped vesicles are present, which are present on erythematous base, and they're present involving a single dermatome on one side unilaterally. So all these descriptive terms, by this time, if you have marked answer as herpes zoster, wonderful, you are on the track. This is herpes zoster, which is the answer here. Herpes simplex, please remember, it is also going to present with grouped vesicles, but where it is going to be mainly presenting peri-orally or in the genital area, but it is not going to follow any dermatome. Okay, and it can cross the midline and involve both right and left sides. Okay, so that is the reason this is not the answer. Molluscum contagiosum, it presents in children in the form of umbilicated papules. Pearly white dome shaped umbilicated papules is a classical descriptive term used for molluscum contagiosum. So lymphangioma circumscriptum, so how does it present? This is going to present with this grouped fluid filled lesions, grouped fluid filled lesions, but remember here there is no dermatomal arrangement. And also this lymphangioma circumscriptum can affect both sides, right and left, so no unilateral involvement. And also pain is not a very common symptom, no pain. So with the help of this, you can differentiate this lymphangioma circumscriptum, which is basically lymphatic malformation. Okay, this is the point which you need to remember. So apart from this, nothing much is important. So this is the molluscum contagiosum lesions which you are able to see here. So umbilicated papules, and this is the orolabial herpes which you are able to see presenting as the vesicular lesions which are grouped, but once they rupture, they are going to leave behind crusting. Okay. So these are the questions which were asked in this paper. I hope all of you have understood all these questions and explanations. If you have any more queries, you can reach me out. I am available on Telegram group